Hi, I'm Emerson Perin, Medical Director at Texas Heart Institute, and today we have the pleasure of having Dr. McCabe from the University of Washington. He is the Director of Interventional Cardiology there, and we have just had an outstanding grand rounds that he gave us on a rather unusual topic, which is tricuspid regurgitation, and it's sort of, it seems like the tricuspid valve is sort of the stepchild of valves in terms of what we think about and therapies. And so maybe we could start talking a little bit about that, and you can tell us about the scope of the problem and how this has emerged and how important it is.
You know, I think you're right that the tricuspid valve has largely been ignored for a long time. Perhaps nowadays you can't say that as much. The FDA has approved 2 transcatheter therapies for treatment of the tricuspid valve just in the last year. So a lot of energy around it, in part because it is such a common problem. So we'll see where things go. I mean, it is a space that is still in need of a lot of information, a lot of data, and we don't have as much background information on this valve as we do on other valves when it comes to, say, a surgical antecedent, right? There hasn't been a ton of surgery done on the tricuspid valve, at least in an isolated way. So we can't lean on our surgical colleagues in the same manner to sort of help us shed more light on things. So I think actually a lot of the transcatheter therapies are going to lead the way when it comes to randomized trials and developing more information to really help us understand what we're dealing with.
And how about the awareness of these therapies? Even though the FDA, this seems to be was a rather rapid approval.
Yeah, yes, you're right.
Tell us about these therapies and how aware people are, what the options these patients might have.
Yeah, well, I mean, the therapies themselves will seem somewhat familiar. We've got a transcatheter tricuspid valve replacement option, which on the face of it seems a lot like TAVR, and I think most cardiologists and even general practitioners these days are pretty familiar with the idea of a transcatheter aortic valve replacement. So the concept of having a transcatheter tricuspid valve is at least familiar in that regard. The implantation, the decision making, the screening, all very different than TAVR, so it is a bit more complicated to do, but conceptually it kind of fits. And then the other space that's been approved is for a tricuspid clip, which is essentially the exact same clip as a MitraClip with a different steering device. So sort of the delivery sheath is slightly different. So that also, you know, for people who understand edge-to-edge therapy or on the mitral side, they'll at least get the idea. Again, it's a little bit more complicated to implement because on the tricuspid you have multiple commissures, not just one as you do on the mitral, and this sort of strategy about how to effectively offer tricuspid clip is a little different, but at least conceptually I think some of it will, you know, ring true to people. Whether or not they're thinking about that on a routine basis, we have some work to do there, I think. Yeah.
Well, I think the awareness is an important thing, and I think people probably will be thinking more and more about this. Mm-hmm. Now, if you can kind of project into the future, because you know right now we're sort of crawling or getting started. Yeah. But how do you project the impact of these therapies, and where do you think this can go?
Well, I think that there is an extent to which we're building the plane while we're flying the plane, and there will be information that will come to light as we sort of parse out either future TVT data or sort of get more granular on the randomized trial data that we have. So that's going to really help us understand who are the right patients to treat, because as was mentioned earlier, tricuspid regurgitation is a very heterogeneous population of people. We also, I think, have questions about the timing of intervention and when is too early, when's too late, what's just right. I think that's really unknown. And then beyond those, we will still have questions about what is the right therapy or the right, you know, what does precision look like? Maybe we should say it that way. There are things we don't have still, like an annuloplasty system, which hopefully if I'm looking towards the future, that's what I really have my fingers crossed for, is a catheter-based annuloplasty system. I think a lot of the problem tends to be free wall dilation of the RV, so being able to pull that in would be really nice. But we will see. We'll see where it goes. I mean, honestly, every aspect of this is still a bit of an open question.
But do you think this will be something commonplace in the arsenal of a cath lab and interventional cardiology in the future?
I see. I don't think it will be every place in the same way that TAVR is every place, at least not in its current permutation. The imaging requirements of intervening on the tricuspid valve are so elaborate at this time that it's going to be pretty challenging to sort of roll that out to all the cath labs. There's also some fundamental issues about how invasive imagers are reimbursed and paid, which create a hurdle. But even if we get beyond that, then you still have to build out a cadre of people to work with the interventional cardiologist, the structuralist, so they can see what they're doing. And that takes a certain amount of expertise. So no, I don't think it's going to be in every cath lab. I do think there'll be expansion, of course, and as things get easier, it'll roll out to more and more cath labs. But at the moment, I think it's going to be kind of slow adoption.
You had mentioned, and I think in the beginning of your talk, what the current penetration or the amount of cases, and I recall it was very minimal, right?
Yeah, on the surgical side, that is true. So, if you look at the United States, there's about 1,200 cardiothoracic surgery programs, and the adoption of isolated tricuspid valve surgery at those programs is really low. It's 0.5% in terms of the number of people with TR who get treated. Less than 1% of all cardiothoracic surgery programs do more than 5 isolated tricuspid valve surgeries per year in the U.S. So that has not spread, and I think transcatheter therapies may spread more than that, but we'll see.
All right. Well, I think this is a very exciting area, an area that just has incredible growth potential, and I think we'll be thinking more and more about this, and maybe this will afford some very significant clinical benefit to patients in some of the areas that right now we're not being very effective or impactful.
Yeah, I think I hope you're right, because medical therapy is mostly just diuretics right now, and people don't love that. We are seeing some quality of life improvements for sure with effective therapy, so fingers crossed that we can really help people feel better.
All right, great.
Yeah.
Well, thank you so much for coming here today. We really enjoyed your grand rounds.
Thank you so much for having me.